Thank you so much for the invitation. I just want to reiterate what I said at the wonderful conference in Oxford, which is that I just have very deep gratitude to Rupert, Sarah, and everyone who's been involved in creating this community of folks who are interested and share this common interest in ketamine and similar compounds. So I apologize if there's a lot of overlap between what I'll speak about today and what I spoke about at that conference. But Sarah did ask me to come now that the paper is officially up online and go through this data from the study. So I'm happy to do so. And it's really my honor to be here today. Okay, so the study that I'll speak about really came from two different sparks of inspiration. The first, as we all know and love, is this exciting literature on rapid-acting antidepressants, in particular intravenous ketamine, and its ability to achieve depression relief in hours instead of weeks or months. The other spark is really from this realm of automated or computer-based or digital therapies, where this has ignited the hope that we might be able to really radically increase patient access to evidence-based care and reduce the costs, burdens, aversive consequences that may be a part of care. So this study attempted to synergistically combine the advantages of both of these inspirations. And in essence, what we tried to do was to think about ketamine as a short-term plasticity booster for learning. So I mean this term very broadly in the sense of neuroplasticity being the brain's capacity to flexibly adjust and reorganize itself in response to a changing environment. And we know from some classical findings at this point, largely from animal neuroscience, that we can see in the face of exposure to chronic or prolonged stress, a sort of decrement in certain aspects of neuroplasticity, in particular, some findings around withering away of the spiny synapses on dendrites in key circuits that are implicated in behavioral and affective regulation. Like the medial prefrontal cortex and limbic areas such as the hippocampus. And this concept of synaptic disconnectivity has been then integrated into models of psychiatric conditions such as depression and are posited to be a key target for achieving recovery, to be able to get plasticity back where it needs to be. But as a psychologist, I've also really been fascinated by this question of whether this is all quite in line with what patients say to us when they describe getting stuck in a limited space of possibilities and options, and a place where we just can't imagine or actualize a more flexible way of being, a way of thinking in the world, where maybe multiple options could be freely chosen. That just doesn't seem possible anymore in the face of something like depression. So in my research program, I've been working from this basic conceptual framework regarding this construct of neuroplasticity and how it might relate to a wide range of psychiatric conditions. And I had the privilege of working with the late, great Do-Nguyen, one of the preeminent animal researchers in this area, on a review paper published in 2020, where we were just trying to flesh out how we were seeing things from this integrative perspective as potentially all pieces of the same puzzle. So we're interested in whether deficits that have been described in neuroplasticity mechanisms at kind of neuronal and molecular levels might propagate up the system in human patients. So you might see this manifest then as dysfunction and disconnectivity within neural networks that has been found in human patients using neuroimaging techniques, which then may bias information processing and decision-making in rigid and maladaptive ways, affecting attention, memory, self-attributions, and many more aspects of cognition. And just in ways that constrain and limit our experience of each and every environment that we enter. And then ultimately that would yield the symptoms and affective states that patients describe. But what I'm really most interested in ultimately is to use this as a roadmap of sorts to creating novel interventions that get people well quickly and hopefully keep them well for the longer haul. So over the past decade or so, I've been really drawn to focus on integrative or synergistic treatments, where the idea is that we might get a stronger and more efficient positive outcome if we can tackle multiple levels of analysis simultaneously. So we're using a range of methods to try to kind of target the brain and open a window of plasticity to introduce useful opportunities for learning or skill acquisition into that window. And so that is really the theoretical framework for this study that I'll speak on today for the remainder of my time. So of course, we know that ketamine is thought to rapidly induce greater levels of neuroplasticity and perhaps quickly remediate some of those same deficits that have been described in the context of chronic stress exposure. So, there's many findings in animal neuroscience that support this more dominant model of how ketamine is achieving its effects. For instance, this data from Morosawa and colleagues published in Science in 2019, where they showed that ketamine not only induces this rapid proliferation of synapses on dendrites, but if you then can optogenetically delete those new synapses that sprouted in response to ketamine, you can reverse some of the antidepressant-like actions. So suggesting that this is at least a core piece of the puzzle when it comes to ketamine's effects. So much of this insight, I would say, comes from animal studies at this point. And so I think there's still quite a lot to uncover with respect to how these sorts of plasticity mechanisms actually get us all the way to a clinical improvement in a human patient. We've been trying to collect data across all of these levels of analysis, pre and post ketamine, in the context of our randomized controlled trials. And so we will hopefully have many more stories to tell from that data that's been coming in. But for today, I'm just going to back up a bit to explain some of the legwork that went into the randomized trial design for the recent publication in AJP. So this means going back all the way to 2009, I believe, and my first foray into ketamine treatment, where we are looking at how ketamine affects plasticity, if you want to apply that term broadly, in being able to kind of show a rapid shift in cognition, and particularly in loosening up self-representations and implicit self-associations. And so to measure these self-representations, we've used the implicit association test. And in these particular early studies, we were focusing on suicidality in particular. So we used this as an index of implicit suicidal cognition with respect to the association between me, myself, and suicide-related concepts, such as the idea of escape. So in this example of what the task actually looks like, you see that words that are related to me or to escape both require a left key press. And so you do a block in that condition, and then in a separate block, the pairings are just swapped. So now, in order to respond to stimuli related to me and stay, you press the same button. And so it's the contrast between performance on those two blocks that gives us a performance-based index of how closely aligned these two concepts are in mind. And so we found in this first open label, very small study, that from pre-ketamine to 24 hours post, we saw a rather large shift in performance on this task that was indicative of a strengthening of associations between me and, a lessening of associations between me and escape relative to me and stay. So these associations became weakened rapidly after ketamine. And we found that there were correlations across patients in the degree to which these shifts on the task occurred, as well as on similar other iterations of the task where we were using other suicide-related concepts like me and in relation to death. The shift in performance mapped onto improvements in explicit suicidal thoughts reported by the patients. So this was a very small N, but we later replicated the same pattern from pre to post ketamine in the context of a larger randomized control trial with a midazolam comparator. So we saw again that seems like that there was a window of plasticity in the way that one views oneself and associates the idea of me with other clinically relevant constructs, at least in the context of these data. So this is what led to a specific hypothesized window of opportunity. So we think of depression just more at a conceptual level as perhaps being characterized by this sparsely connected network where there's just maybe some very well-practiced pathways that represent things like self-loathing, but there's not a lot of flexibility in being able to see different perspectives. And so ketamine is sort of like airdropping in a lot of bits and pieces of pathways and roads that are then available. So in that window where those might be available, we thought we could introduce cognitive training when the brain has been rapidly restored to this healthy state where healthy learning processes can be leveraged. And so the goal would be to treat that as a window of opportunity and practice kind of repetitively driving those pathways that we think would be most therapeutic and really antithetical to depression, in the hopes that we can create this, this protective and enduring state that would keep depression at bay. And so this is the sort of crazy idea that we tested in this randomized control trial, was to really just simplify this to a computer-based digital therapy that we called automated self-association training, or affectionately known as ASAT. And we were drawing on this literature that comes largely from social psychology, where there have been these computer paradigms developed under the umbrella term evaluative conditioning. But essentially, they're designed to move somebody's liking or preference towards the more positive side through repeated associations, just your basic kind of classical or Pavlovian conditioning that is being leveraged to induce more liking or preference towards a stimulus. So in this case, what we want to induce liking of is me, myself. So we had a few different paradigms that we could draw from where there was maybe a hint of some clinical potential even for these types of learning mechanisms. And so we packaged these together into this novel intervention, really trying to go after self-worth in the context of treatment-resistant depression. And so to give a little bit more detail of what this looks like, so we had two versions of the task that were both word-based or lexical. One was using subliminal presentations of words. The other was using supraliminal. So when it's the subliminal version, you have the letter I standing in for me, myself, blipped really briefly for 17 milliseconds, followed by a positive term such as good, blipped again really, really briefly. And then in the supraliminal version, they stay on the screen for half a second so that they can be really consciously perceived. But in both cases, they're just being paired over and over again. And then there's a sort of incidental task that the participant is completing at the end of each trial. So the stimuli appear, and then after that, they have to respond by pressing a button to indicate, for instance, whether this letter string starts with a vowel or a non-vowel. And so these are done very repetitively, 120 repetitions per ASAT session. And we gave a total of 8 sessions total. So we're doing it quite a number of repetitions, very systematic, but at the same time can be done quite efficiently. So this whole set of these 2 lexical tasks takes maybe between 5 and 10 minutes per session. And then we also can create a really nicely matched sham version of the same computer tasks, where we just remove whatever we think is the therapeutic content, but have the exact same computer tasks be completed. So in the sham version, the letter I was instead the letter X, and then it was paired with neutral words in this case. So everybody got both of those paradigms. And then finally, everybody also got a pictorial version, where in this case, we took photos of the patient as the self-stimulus, 3 different kind of angles. And the photo of the patient would appear in any of 4 spots, kind of quadrants on the screen, and they were asked to just click as fast as they could when they see a picture. So they clicked on the picture of themselves, and then immediately this was replaced in the same location by a smiling face from a standardized stimulus set used in psychology research as the positive stimulus that we're pairing with the self-stimulus. And again, this is very repetitively done. So in this pictorial version, there were 480 repetitions per session times the 8 sessions. And then we have a sham version where the pictures that they click on are of a stranger. And then the photo that replaces it could be a variety of different facial expressions, but mostly neutral faces. So in our randomized controlled trial, we had 154 patients with unipolar depression who enrolled and were randomized, and they must have failed at least one FDA-approved antidepressant medication. So they had varying degrees of treatment resistance within this sample. They could continue any antidepressant treatments that they were on as long as they were kept stable and as long as they were still meeting our threshold of a MADRS score of 25, so moderate to severe depression at baseline. And then they were randomized in this 2-to-1 scheme to receive a single infusion of either ketamine or saline. So here you see the two arms here both got ketamine. These individuals with the blue line got saline. So this is just the initial impact at 24 hours on MADRS scores of ketamine versus saline. So we have a 52% responder rate in the ketamine arm, 28% remission rate. So in line with the existing literature on what a single infusion of ketamine can do. But then these patients down here who got ketamine were further randomized to either active ASAT or the sham version. And so then they proceeded into completing 40 minutes total a day for 4 days back to back, starting right after that 24-hour assessment was taken. So this design gives us 3 arms and includes the active-active combination in orange, but also a comparison group that got ketamine but lacked the active behavioral component. That's the people that got ketamine followed by sham, and also a control arm that got the active treatment, active behavioral treatment. They got the active ASAT, but they didn't get the drug. They got saline instead. And then we gave no further intervention and just followed them for a month here with our MADRS readings. And what we found was encouraging to see that with this very minimalist kind of targeted approach, completely on the computer, we were able to see a lasting impact out to 30 days, where this single infusion seems to be mostly maintained. And the best kind of statistical description of this is that it's simply a steady decrement in depression across this entirety of this 1 month. So this was encouraging. And we also noted that it doesn't look like it's waning at all. Whereas in the ketamine treated patients who got the sham version, we saw what you would expect after a single infusion is that over the subsequent weeks, they're kind of creeping back up towards the placebo arm, the saline arm. And so we've then followed them further, in a naturalistic follow-up. So after the 30 days, they were no longer asked to keep stable treatments. They could, go back into the community and get whatever treatments they'd like. And we just sent them self-report measures over an entire year just to see how long might this last. And so what we have now concluded and wrapped up just as of a week ago or so is that 1 year follow-up. I'm showing you here the last point in time at which we actually see a significant group difference, and that's at the 3-month mark. So it looks like this is just the effect at day one on the QID scores, but then you see that the group that got ketamine plus ASAT remains lower than the other groups even 3 months after this very kind of efficient 4-5 day intervention way back here. After that, they start to kind of coalesce and no longer are the groups significantly different. So it looks like we got about 3 months or so of mileage from this approach. Since these findings came out, they have attracted a lot of media attention. So just want to touch for a moment on what we didn't do in the study. No, we did not cure depression with a smile. No, our findings do not mean that if we all would smile more at one another, we could help people with treatment-resistant depression. That may or may not be true, but that's not what we found in this study. We also did not serve ketamine with a side order of smiles. In other words, we did not, our data did not suggest that if you were to leaf through a magazine of smiling models in advertisements at your ketamine clinic that this would somehow extend the effect of the ketamine. Some of the comments put in response to some of this media coverage, I had to have a chuckle. Somebody mentioned that the treatment sounds like a Saturday night clubbing in 1999, and I couldn't disagree with that characterization based on what the actual news story presented. But I hope I've highlighted just how kind of systematically and we were using these paradigms and how they were developed based on really about 50 or 60 years of prior research developing strategies to try to move this aspect of cognition. So I'm just mentioning here that I'm fortunate to be partnering with the Pitt Innovation Institute with a goal at the end of this winding road, which is all new to me, but really the goal is to see if there's a way to get this intervention to patients and providers who may be interested. So there's multiple steps in here that I'm learning about. So far, we've certainly met this kind of milestone along the path, which is that the institution made the decision to file a provisional US patent on these novel methods and systems. My next steps for this research, I have a lot of dreams. Some are more pipe dreams and some are closer to reality. But of course, it's very important to understand the real world effectiveness by doing a trial potentially in clinics where people are already receiving ketamine and or S-ketamine and see whether this approach has an added benefit in those settings with those real world patients. I think a particularly compelling angle as well is to think about where do we have the most urgent need for an efficient approach that could be delivered within a critical window of time where you have somebody and you have an opportunity. So we have an ongoing randomized control trial of very similar techniques, the same kind of synergistic approach among suicidal inpatients. I'm also interested in whether this could be useful for justice-involved individuals in crisis management in kind of prison settings or even in the transition back to the community, being able to use a window of opportunity to help set somebody on a trajectory that might be helpful, or even returning essential workers to the job where they're in very high stress jobs and are needed back on the job in quick order, but also suffer from high rates of suicidality and depression. And then, one thing that's nice about these techniques is that you can envision how they could easily be tailor fit to specific clinical symptoms that a patient presents with, or to a broader range of clinical disorders, just based on this simple classical conditioning approach. So thank you so much for having me once again. Thank you to some of my key collaborators, and of course to my family and to NIMH and the Laurel Zach Memorial Research Award for supporting this work. And I am happy to stop there and take questions.
Thank you. Thank you very much, Becca. It was a terrific talk of incredible work. I wonder if somebody has some question, and if so, please feel free to ask it or like just write them in the chat and we can read it. Or if you want some more time to think about it, I may have some of my own to start. So, well, and I think we already have one, yeah, in the chat. I think Tiago was asking if you can talk more about the process of, I think, your computer-based psychotherapy here. Can you see the chat? Can be translated.
Okay. Yes. Thank you for these questions. So the short answer is that we don't have a polished and ready to roll out version, and I'm trying to make that a reality. And I've been really amazed and overwhelmed by the response that we've gotten from patients and providers who seem to agree with me that we have real need for something like this. And I'm very hopeful we can get it out soon. As of now, it's very much just sort of your homegrown research software, do it yourself, and not ready to disseminate. So I am very interested in making that into a reality, and there's certainly no reason why we couldn't, have it be available in multiple languages. This is really simple learning processes that we're working on that, certainly would be applicable across, I believe, all human beings. So we just would have to, have some slight tweaks to the actual stimuli that are presented in order to present it in different languages, and again, kind of target different potential profiles of symptoms. The process is really just the pairing together of in our case, what we're going for is the self-related stimuli and the positive stimuli in a variety of different paradigms. But we did it in a packaged way where multiple people where everybody's getting multiple things. So it could be, for instance, that the subliminal presentations, which are blipped very fast, are a very important part of this. And that, I think is much easier to accomplish with a computer. So I think that, we don't know exactly which are the kind of necessary and sufficient ingredients. We just know that what we tried in this first study worked. So I think, the question about whether a psychotherapist can deliver this, just don't have the data on that. But I think that some of these paradigms, especially the subliminal presentations, would be challenging to replicate without using a digital platform. How long is a patient session? So each session we gave takes between 15 and 20 minutes. And what we did was we gave 2 of those per day for 4 days back to back. And we spaced them out in between with a little 20 to 30 minute break in between the 2 sessions on that day. So all in all, the patients were in our clinic for about an hour for those 4 days following the infusion. The subjects in this particular study complied extremely well with the sessions. There was about 98% compliance with the full protocol of sessions. That, again, is in a research context. So whether that same compliance would be achievable in real world settings remains an open question. I can say that when we have gathered sort of acceptability type information and satisfaction ratings from patients, they are tending to rate it quite high. So it seems to me that at least the patients enrolled in our studies are finding something that they like about completing these exercises. I don't think anyone is trying to replicate it other than us as of now. So we have our second RCT in the suicidal inpatients just after a suicide attempt. We enroll them in that study. So that will be our first replication attempt, but that's very much an effectiveness kind of really real world study where we have a lot of challenges in just kind of logistics of getting the protocol completed for each patient. So it'll be for sure a much messier test of the hypothesis compared to the outpatient depressed study where we had, like I said, very high compliance with the protocol and such. Okay, do the error bars overlap between ketamine ASAT and ketamine and sham at 30 days? So for the MADRS, I'm sorry, I believe that for the MADRS, there was a significant effect for those 2 groups at 30 days. But for the QIDS scores at 90 days, you're correct. The ketamine versus ASAT, the ketamine plus ASAT versus saline plus ASAT is the one that remains significant. And the ketamine plus sham group doesn't differ from the saline arm. But that specific contrast between the 2 ketamine treated arms is not significant in that data.